Right to the panel session today. We have Mr. Alumni sir. He is a neurologist and speech language pathologist at Dinana Foundational Hospital and also owns a Rajapad's hearing aid clinic. He has major achievements in laryngology, voice conferences, and speaker. He's been a faculty to the fellowship program for speech language pathologists at BMH. His area of interests are voice rehabilitation and audio rehabilitation, and he has few publications to his name. Sir, I would like to call you on stage. Can we have yes. Now I would like to ask sir to introduce his panel members and start with the session.
Thank you, Durga. Thank you, Alumni and Alumni for giving me a wonderful opportunity to speak along with these three beautiful, brilliant, and wonderful ladies. First I am going to present, then Tanaya will present after me. She has done MSc in speech language pathology. Currently, she is doing fellowship in speech and swallow. Her major achievements are National Cancer Week Advanced Tracheostomy course. And currently, she is pursuing a fellowship in speech and language in hearing oncology in then anyway laryngology and voice rehabilitation. Then after her presentation, Alifia is going to present. Alifia is a founder and clinical director of Therapy Tel Speech Swallow Clinic and Rehabilitation Center. She mainly works in LSVT. She is a certified person who can guide to the people who can learn from her. And her area of interest is neuro rehabilitation, dysphagia management, cognitive rehabilitation, speech and feeding therapy, Parkinson's disease rehabilitation, swallowing evaluation, pediatric feeding, and communication disorder. And then at the end, Rexy will be going to present. She is a consultant speech language pathologist and audiologist, and her major area of interest is neuro rehab, motor speech disorder, voice, and autism. So now we'll start with my presentation. So my topic of presentation is stroboscopy. In this presentation, I am audible. In this presentation, we will learn about what is stroboscopy. Then we will recognize the use and care of video stroboscopy equipment, identify normal anatomy, normal function, and abnormal findings. And then at the end, I will try to show you how to interpret the strobe exam with the various parameters. So let's start with the basic terminology. What is an endoscopy? It is a technique used by a physician to view any internal body part. It is called as an endoscopy. Then what is a laryngoscopy? Laryngoscopy is viewing only larynx through the endoscopy. Then what is a stroboscopy? When we use strobe light during the laryngoscopy, it is considered as a stroboscopy. Then what is a video stroboscopy? When we perform stroboscopy, and then we are able to save it, and then at the end when we do a recording and we save it, and at the end we will again interpret that recording for further evaluation, that is a video stroboscopy. These are two types of scope through which we can perform stroboscopy. First is a flexible scope. Flexible scope is similar like a thin tube. Okay, camera is permanently fixed at the end of the tube. Okay, and we insert this flexible scope through the nose and we see the larynx. Okay, so what is a rigid scope? A rigid scope is similar like a rod, but camera and light source both are attached separately, and we insert this rigid scope through the mouth. Understanding how strobe works. Strobe box has two types of light, a flashing xenon and a constant halogen for a constant viewing. A mic and EEG is used to detect the fundamental frequency of the vocal cord. It is very important to fix the EEG and mic, because if you will not fix properly at the laryngeal level, then you will not be able to see mucosal waves properly. Okay, because the flash is synchronized to the pitch rate. Unless and until you will not fix that EEG, the pitch is not synchronized properly. The flashing strobe light creates an illusion that the cords are moving in a slow motion, but it is actually a composite image sample from a variety of glottal cycles. It is slightly technical and very difficult to understand maybe, so I will explain you this in a simple way. Now I want you to focus on these two images. Okay, so image A is showing different position during one glottal cycle, only one glottal cycle. Okay, now assume person is phonetic and camera will click one photo of each movement or each position at one time. Means first glottal cycle, first position and first move. Okay, so image 1 here and that position 1 there is same, you can consider that. Okay, so similarly, second glottal cycle, second position, second move, third, fourth, fifth. Similarly, it will happen, and then at the end, the computer will arrange all these images, these 9 images, and make one composite image, and then it will show us as a one glottal cycle, just like a summary. Someone gave presentation and someone gave just a summary. So this is a summary. Okay. If you are still in confusion, then just focus on these two scopings. First is a real-time high-speed scoping. So what is a real-time high-speed scoping? For example, if I am able to produce 110 Hz frequency, so it means approximately I am able to produce 110 glottal cycles in 1 second. So through your naked eyes, you will not able to see all the glottal cycles. But if you use a high-speed camera is just like a slow-mo, but a very sophisticated camera is used during that slow-mo. So you can see each and every glottal cycle. Now vocal cords are adapting and the mucosal waves will be there. Now this is the first mucosal wave, second, third, fourth, fifth. Now it is actual real-time mucosal wave what you are producing. But if you will perform stroboscopy, then it will show you like this. So you can see hardly 1 or 2 mucosal waves in a 1 second. Okay, so that's why it is called as a illusionary effect. Okay. So now you will think, then if the strobe is giving illusionary image, then why we are insisting to do stroboscopy? So this is a study done by Saklov et al. In 1991. As per this study, around 47% diagnosis was incorrect. They didn't perform the stroboscopy. That's why they diagnosed something else. So it is very important to diagnose through the stroboscopy, and it is important for SLPs also. So these are some benefits. We get a better diagnosis and intervention. if the person visited our clinic, then if you see the stroboscopy, then you can understand whether that person needs surgery or we can continue with the speech therapy, and we can decide speech therapy goals also. So that's it. This is the end of theory part. Now we will move to the practical knowledge. So be ready for we are going to perform the stroboscopy. So we have to check all these things. Check mic, EGG, hand gloves, mask, lubricant solution spray is a local anesthesia spray, lens cleaner spray, anti-fog solution, and high level disinfection solution. Yesterday someone said if we perform stroboscopy or some other scopy for the HIV person, then we can't perform or use that scope. But we use a high level disinfection solution like a Sidex. We keep that scope into that Sidex for there are some particular 4 hours, 5 hours, something like that, and then we can use that scope again. These are some precautions we have to take care of. Explain the entire procedure first, so the person will not get any sudden laryngospasm or something like that suddenly. So you have to be calm and you have to make patient calm, and then you perform the stroboscopy. So these are different types of scope, different diameters of scope. So you can use as per the patient's age. And this is how the sitting position is there. Now this is the Sidex solution we keep. As we have a 3-4 scope, we keep each and every scope in the Sidex solution. Now there are 2 light sources. This is the one light source and this is another light source. So whenever I want, I ask her to change the light source. So she will give proper light source to whatever I want. Then she will clean the scope, and as I said, this is a very important part. Put EGG and mic properly and check whether that is working or not. You can see intensity and frequency on the screen. Fundamental frequency you can see. Give basic instruction and then spray. It is very bitter in taste. This is how we spray. And this is how we start the stroboscopy. First make patient comfortable and then start. Yes. So we insert it through the cavity. I check there was some obstruction. Then I remove the scope. I insert it through the another nostril, and then we enter into the first nasal cavity, then the nasopharynx. Here on the screen you can see the fundamental frequency and intensity. This is the nasal cavity. This is the uvula, nasopharynx. Now this is the base of the tongue. Epiglottis, epiglottic cord. You can see right vocal cord, left vocal cord. You can see a tracheal rings properly. Now these are different kind of eye scan. We use this eye scan for a better visibility. We have 3 different eye scan. Now these are basic parameters, and we make a diagnosis by analyzing these 7 parameters. This is how we select the appropriate options and for each parameter. I am going to discuss each parameter separately in the next slides. So let's start with the fundamental frequency. This is a scopy of a normal way, a professional singer. You can see how the mucosal waves will change as the person will change the voice frequency. Now this is a normal pitch, Entire vocal cords are moving. Pitch right. This is a glottal fry. You can see a one more scopy again to show mucosal waves, but in a pathological condition. Nodule, these are nodules, and you can see hourglass closure also in this scopy. Anterior 1/3 nodules. Mucosal waves are there, but hourglass closure is there. Closure is not proper. Now, amplitude. In this copy, you can see how amplitude change. What is amplitude? It is a extent of horizontal excursion. Means when the vocal cord meet with each other, each vocal cord vibrate from central point to the lateral and then back to the center. So this is amplitude. Okay. So very important thing is what? When vocal cord meet each other. This point you keep in your mind. At the end I will show you one more scopy. There you can see there are no mucosal waves. Why? That I will explain you. Now this is the case of pathology dysphonia. You can see now there are spasms, and at that time mucosal waves are not there. But when there is no spasm, mucosal waves are there. See, mucosal waves are there. No mucosal waves, no mucosal waves, gradual mucosal waves. So amplitude is affected when there are spasms. Glottal closure. These are different types of glottal closure. Regular when there is no pathology. Hourglass closure usually there in nodule. Irregular when there is some kind of pathology like a granulomatous lesion. Bowing is mainly present in palsy case or presbyopia. Posterior phonatory just I showed you. And incomplete closure. Incomplete closure and bowing, these two are different things. Okay. When there are like a sulcus vocalis, then there is an incomplete closure. Okay. So this is a sulcus vocalis case. You can see a normal mucosal waves, but constant phonatory gap is there. There is no glottal closure. These are not bowing of vocal cord. Okay. This is a grooving of vocal cord. You can see some part is like someone scooped from the mucosal waves, just like we scoop ice cream. See, there is a constant phonatory gap. Vertical level of approximation. It means whether the two vocal cords are at the same level or there is any kind of mismatch. Okay. Sometimes in vocal cord palsy, one vocal cord is slightly below as compared to the other. Now in this copy, left side is a palsy, but slightly right side is below. Usually it happens like that way. Other vocal cord push downwards because the other opposite false cord compensate. In that image also you can see a proper one left vocal cord is going and right vocal cord is pushed below. Periodicity, when there is a uniform vibration in amplitude and time wise. So you can see the periodic vibration, and these are the aperiodic vibration. Okay. So this is a right vocal cord cyst case. You can see a reduced mucosal wave at the lesion area. Posterior part is properly vibrating, but see, reduced mucosal waves at the lesion. Got it? There are mucosal waves on the side, but less. Symmetry of bilateral movement, degree to which two vocal cords provide mirror image to one another. If both are periodically vibrating, then there is a symmetry. If one or both are aperiodic, then there is no symmetry. Now in this case, there is a scar on the right vocal cord. You can see a right side mucosal waves are not symmetrical. Both are dancing separately now. See. and that's why there is a phonetic gap. Okay, got it? So what is the take-home message? SLP can identify subtle abnormality that might be missed with the other assessment method. Stroboscopy help SLP identify the specific type and location of the vocal cord lesion. SLP can monitor the effectiveness of treatment by comparing pre and post treatment. And last point is very important, finding from the stroboscopy can differ based on the individual experience and perception. So if you want to be expert, then try to see the video and not the ready-made reports. Usually whenever we see the stroboscopy and report, we don't see the stroboscopy. We see just report, and then someone is saying sulcus. Okay, we don't think whether there is some other problem. Yes. Most of the time, if I ask interns come, then I ask what is the diagnosis. They say phonetic gap. Phonetic gap is not a diagnosis. Phonetic gap is a finding. Just like similar in audiogram, when there is a 2K notch in BC, what is the diagnosis? So 2K notch in BC. It is not a diagnosis. It is a finding. Diagnosis is autosclerosis. So you have to think in that way. Now, I will show you 4 cases. I have mentioned the things what exactly you have to observe, which will help you to understand in a better way. So, this is a case 1, a 35 years old female teacher by profession, history of vocal cord abuse since long time, case of complaint of change in voice for 1 month, no other medical history. Now you have to observe all these things, and I will ask you what is your opinion. Diagnosis I will ask at the end. You might say something else, that is there is no issue with that. Okay, but try to think. So mucosal waves are present, right? Slightly reduced, you can say. Glottic closure, incomplete. Okay, amplitude, reduced. At the site, periodicity affected, yes. Symmetry affected, yes. And diagnosis? Left vocal cord, hemorrhagic polyp. It's very fresh lesion. Gradually it will accumulate and you will see a proper polyp. Case 2 of 52 years old male, history of right vocal cord CA. CA means cancer. Type 5A chordectomy. Type 5A chordectomy is entire right vocal cord is removed and partially second vocal cord is also removed. Cancer is, it is a precautionary measure. Sometimes cancer is there in left vocal cord also. Okay. Right fat augmentation done recently. Fat augmentation is a monosurgery. We removed fat from the belly and we insert into the vocal cord to reduce the phonetic gap. Okay. It is not a regular scoping. It will help you. There is a new cord formation at the right side. You will not appreciate it, but there is a vocal cord. Okay, it is not like a normal vocal cord, but there is a new cord formation. Now I want you to tell why false cords are vibrating and what is it called? Yes. False cord vibration, right? Yes. And there is no glottic closure. That's why it is a compensating. You can see there are no mucosal waves on the cord. See, cords are not moving. Now cords are not moving because there was a cancer. So when there is a CA, first thing which is affected are mucosal waves. It is a parameter to diagnose the CA. Okay. Now in this case there are no mucosal waves because there is a CA. Now in other patient, now this is a case 3, 60 3 years old male, history of trauma to neck 4 months back, complaint of change of voice after trauma, perceptually very weak voice, hardly audible. Now you can see there is a left side, pulse. Yes. Now here again there is a compensation. There is again false part are coming close. Left side ventricular folds are moving, but you can see movement on the left side, right? On the pulse side. But there is no movement, yes, done. But there is no movement on the right side. Why? Means abnormal cord is moving and normal cord is not moving. So, because during amplitude, I told you vocal cord need to come close together and need to be close. So only then at that time vocal cord vibrate. If there is no closure, then the vocal cord will not vibrate. This, the right vocal cord is moving is because of laxity. Okay. Left side moving passively is due to the air flow and not due to the muscle movement. Okay. So I will not show you both examples. This is the laryngospasm or laryngo. These are spasm or tremor. Yes. Tremors and spasm both are different. Initially I showed you spasm. This is the tremor. The entire larynx shakes. Okay. So don't get confused between spasm and tremors. Okay, that's it. Thank you.
Good morning everyone. My name is Pathology and I have done my BSLP and MSc SLP from DVDU SSLP, and it's been an immense grateful that I am standing over here from the day I have started my journey of becoming an ASLP. So to begin with, that's beautifully explained us what exactly is stroboscopy and what are its instruments and everything. So this is just a brief overview of what we exactly know. So I'm going to go really quick on this. So this is generally what I have faced as a beginning practitioner in ESLP. So what if we do not have a stroboscopy and we have to do a voice assessment? So it is important to start with the perceptual evaluation of the voice. It involves the judgment of a voice sample by either an expert or a native listener. There are several scales. I'm not going to go in detail of it. I'll just give a brief overview of it. We have the Prabha scale. We have the Vatsya as well. We have 8P, which includes visual analog scale on following attributes including readiness, roughness, strain, pitch and roundness, from highly impaired to severely impaired on the visual analog scale. We have revised version of this as well. The fellow voice profile, it contains 7 equally appearing intervals with 1 meaning a slight deviation and 7 meaning severe deviation. It focuses on a 12 initial aspects starting from the laryngeal tone, to diptone, tonia, to nasal condition, and overall voice efficiency. Now there is more of London speed scale which I have not mentioned over here, but it is one of the new scale which can be helpful. It is similar to the Renault scale as well. So now when it comes that what exactly speech sample we have to take when we do this assessment, it depends upon the clinician's perspective, on the scales criteria as well, and center to center. So generally connected speech sample or oral training task or individual vowel formation can also be taken to them. Also, it depends upon, it is difficult initially to identify that what exactly, whether it is hoarse voice or breathy voice or harshness. So it is important to take the consequences from the other team members as well, that what exactly is the quality. And also it is important to record it and view it again. It is important to take pre, mid and post as well in order to have a nice idea of it. Now, as having been said that, It is also equally important to look at a person as a whole, because voice condition is not only just on the whole, but you have to see as a whole, including how is the posture, how is the breathing pattern of it, how is the MPT, surgery issue. So it is very important to look into the subsystems of the speech, and like phonetics system, how is the vocal fatigue of it, how is the voice quality of it, or the prosody of it. So it is very important in general to observe it. It is not just perceptual assessment. It is not just we are giving it some reading task and just to assess it. It is about that to observe it, that how exactly is this voice and how exactly is posture of it. It is also equally important to work on patient-reported outcome measures as well, because according to ICH, it is not just focusing on body function and body structures as well. It is also equally important to look into how it is limiting its activity and how its participation is being affected. So we have various measures. One of them includes VHI. We have VDO as well, voice-related quality of life. We have VDO, which is voice disorder outcome profile. We have BAP as well, which is voice activity and participation profile. These are some of it. So we can use it. Any beginner clinician can actually do all of these assessments easily. Apart from that, we have acoustic assessment as well. So we have empathy, we have PRACS, we have Doppler speech. So there has been evidences which also says that there is a great correlation between all of these factors from Rabasi to acoustical and voice handicap index as well. Also, dysphonia severity index can be also used, which has a good correlation or relationship to Rabasi scale. It is very quick and it is easy to administer with for any of the SLPs. This is just a small table which explains us that what are the 4 tasks which you can actually take and what acoustic measures it is going to measure it. So for a beginner clinician, it is very easy that what task I have to do and what it is going to measure it. Also, once I do all of these assessments, it becomes easier for me in my mind to predict that what might be going inside the throat. So, this is just a brief overview of it, that what exactly we have to do. Case history, perceptual assessment, acoustic assessment, and aerodynamic assessment as well. Also, whenever possible, if we have an access to any of the rigid scopy or flexible scopy, we should do it in order to understand the vocal cord status, even if we do not have access to stroboscopy. Also, having been said that, does it replace our holistic assessment protocol? Of course not. Objective and subjective assessment will always go hand in hand. Of course, whenever we have low resource areas, or we have cost effectiveness, or it is a best tool, or when it is non-invasive, it is extremely important that we do all of these assessment. But of course, whenever we have access to stroboscopy, it is extremely important that we do it, and we should do it. Also, this is just a tutorial which explains about recommended protocols for instrumental assessment of the voice, which actually helps us to give an evidence that even if we do not have an stroboscopy, we can actually look into this task and focus on it, like what exactly we can do. I will quickly have an overview of what exactly voice therapy techniques. So, voice therapy is nothing but it is a process of something new than repairing a voice. So these are general techniques like hygienic voice, symptomatic voice, psychodynamic voice, physiological voice, and eclectic voice. Hygienic focuses on identifying an inappropriate vocal hygiene and modifying it. These are some of the objectives. I will not go in detail of it because we are all aware of it. So I'm just giving a brief overview of it. Hygienic. We have symptomatic. So this has a 25 therapy approaches are there, and which tells us physiological voice therapy, which has vocal function exercises. We have SOVT. We have also, these are some of the evidence which supports SOVT. We have randomized control trials, and we also have systematic reviews as well. RVT also is one of the physiological voice therapy, which focuses on it for various conditions. Also, we have eclectic or holistic voice as well, where we focuses on all the techniques from each of the approaches. So this is just a one case which I used to see to represent. I did not have any stroboscopy, so it was from the assessment only which I was able to identify what could be the diagnosis of it. So he was a 46-year-old. He was a 26-year-old male with a voice change since last 20 days. So he was having history of abuse, he was having GERD, he was having voice which was around 8 hours. And on Grabasi, it was the hoarseness of the voice and also the further MPT, and we have done AHI as well an acoustic assessment. So along with this, it was a hyperfunctional and basic assessment it was being started. So having been said that, I would like to conclude that even if we do not have a stroboscopy, we can still do that assessment. But of course, whenever we have access to it, we should do it. Thank you.
Thank you, Tanaya, for a wonderful presentation. Now, I will request Alivia present on her LSPD.
Good morning, everyone. So today we are going to learn about one of the most evidence-based speech therapies for Parkinson's disease, that is LSPD loud. And it focuses on increasing the vocal loudness, it improves communication and quality of life, and it's backed by 30 plus years of research. So why do Parkinson's patients speak softly? So this section will cover neuroplasticity, LSPD loud protocol, research and clinical application. Parkinson's disease, up to 8 million people worldwide are living with Parkinson's disease. The number of people with Parkinson's disease is expected to double by 2040. It is the fastest growing neurological disorder. More Parkinson's disease patients, SLPs, have an extremely critical role for rehabilitation. So when we ask patients who are newly diagnosed with Parkinson's disease about their therapy goals, most of them say that I don't want to lose anything. So our mission is to empower people with Parkinson's to restore and maintain their highest level of functional communication, mobility and independence in daily life through scientific supported therapy programs. And those living with Parkinson's for longer often want to do everything just like before, move well, have the energy, maintain balance and communicate very effectively. So Parkinson's, there are two kinds of programs for Parkinson's, that is LSPD loud, which is used by speech therapists, and LSPD big, which is done, practiced by physical therapists and occupational therapists. Patients don't say that I want better articulation, they say I want better communication. So it is a stunning time to be in rehabilitation today. Basic science evidence for the value of exercise in Parkinson's disease has been established, that is classical drugs, surgery, etc. Researchers have identified key principles of exercise that drive activity-dependent neuroplasticity. High effort rewires the brain, whereas repetition strengthens its pathways. Clem Jones in 2008 and Ludlow et al. In 2008 demonstrated that exercises can improve brain functioning, that is neuroplasticity, and may slow symptom progression. So exercise is the medicine. Rehabilitation is becoming a routine part of the management in Parkinson's disease to provide symptomatic relief and to improve its function. I would like to share a video before and after LSPD. A 59-year-old female, 2.5 years since diagnosis, there was changes noted in her voice and in her speech. She is on medication in the before and after video, and she had no changes in medication. intensive 1-month speech therapy program was being followed with her. I want you to observe the changes in the loudness, the facial expression, the confidence.
I am suffering from Parkinson's and I have got difficulty in speaking.
What did you notice? Little slurring, reduced mouth opening.
In pathology, and I can make it in 2 ways, with more.
So there was not only changes in the vocal loudness, but also improvements in the quality of her voice, her speech clarity, her facial expression, and additionally, ability to express her personality confidently came through post-treatment.
Avoid the vegetables with
This was after intensive 1 month of LSVD. Okay, so over 89% of individuals with Parkinson's disease worldwide suffer from voice and speech disorders. There is reduced vocal loudness, monoloudness, hoarseness, harsh, ready voice quality, monotone voice, imprecise articulation. All the cause is hypokinesia, that is reduced movement amplitude. Impact of speech changes in Parkinson's disease. Even people who are clinically asymptomatic for speech deficits report feelings of embarrassment, social stigma and social isolation due to speech concerns. So does this matter? Consequences include being excluded from conversations, a loss of dignity and feeling of misery for many. Natalie, an individual with Parkinson's, expressed, "If I have no voice, I have no life." Classical medical treatments alone do not consistently or significantly improve speech in PD. Phonological treatments, there is no evidence of systematic improvement in dysarthria owing to dopamine replacement therapy. Surgical treatments such as neurosurgical interventions also do not consistently or effectively improve speech in Parkinson's disease. Speech problems need behavioral therapy. Despite efforts to improve the voice and speech in Parkinson's disease, 1987, no effective voice or speech treatments were available for Parkinson's disease. This is a picture of Mrs. Lee Silverman. So, Mrs. Lee Silverman had Parkinson's disease and it was her family's wish to improve her communication, and that motivated Dr. Ramek, who began the work, and it is known today as LSVD Loud. That is Lee Silverman voice treatment. This is a summary of the research that supports LSVD. When we talk about LSVD, it's important to understand how it evolved over time. And it all started in the 1980s with Dr. Ramek, who was working with a patient named Lee Silverman. And at that time, there was no effective therapy for Parkinson's disease. The traditional approach focused more on articulation and breathing, and they were not giving results. So she discovered a very powerful principle that the core problem wasn't articulation or respiration, but reduced movement amplitude, that was hypokinesia. So instead of trying to fix multiple systems, the therapy focused on one key target, that was loudness. And then came the research phase, that is phase 3, phase 3, and which is actually the backbone of LSVD Loud. And over the years, multiple randomized controlled trials and all were conducted for LSVD with no treatment and with other speech therapies. And they measured outcomes like loudness in DBSPL, communication effectiveness, and long-term retentions. And these results were like really strong. Patients showed significant improvement in loudness that was maintained even after 6 months, 1 year, even up to 2 years. I have a video which I will show where after 7 months, how LSVD, how he has maintained the loudness. So in my Parkinson's patients, when I push loudness, I automatically get clarity of speech and better intelligibility, even without directly training articulation. So LSVD is not a casual therapy, it is like physiotherapy for the voice. Intense, repetitive and effortful. LSVD loud, there are certain key concepts which incorporates principles of neuroplasticity, and it is administered in a very intensive manner to challenge the impaired system. We work on target, mode and calibration. Target is amplitude, which is vocal loudness, mode is intensity, high effort, and calibration is generalization. So we are always training the healthy vocal loudness, and never it is a voice that is harmful or it is too loud. So under-scaled movements and with a healthy vocal loudness, it drives amplitude to override bradykinesia. The goal of LSVD is also to foster healthy vocal fold closure through exercises and shaping, that is modeling from the clinician. So here are the pictures before going and after picture with better closure. It improves voice quality and phonation. If you observe in the first video, the bowing on the chords. And post-treatment. Better closure. Okay, so the intensity, as I told you, it is a high effort. It follows 3 neuroplastic principles: high effort, intensity, and calibration, right? So intensity across sessions, this treatment is delivered 4 consecutive days a week for 4 weeks. 1 hour individual treatment sessions, daily homework practice all 30 days of the month, daily carryover exercises for 30 days of the month, and lifelong habit of continuous practice. And intensity within sessions should be high effort, which focuses on amplitude, repetitions, force, resistance, accuracy, and fatigue. Would like to share a video. He is known case of Parkinson's. He also had brainstem stroke recently, and intensive LSVD used along with our other exercises. And this is how he's maintaining vocal loudness even after 7 months.
Okay. I have very loud. Yeah. Unfortunately, I had a brain stroke one day, and then
I met him after six months or something, so I had an opportunity to just capture the video because he was using the techniques and exercise very well.
I had great difficulty, and I had that gratitude attached to me, which I was not very fond of. But Dr. Ilya helped me with that, and she restored that confidence into me that I can do without the right tube. I can do my swallow, and initially I had a slur in my voice, right? So, those are not a good days which I was not like very much. But luckily I met Dr. Aditya, and she brought great changes with me. She suggested certain exercises. Of course, she is a little strict, so already not going to that right now because she's sitting in front of her. But it did certain exercises she showed me, like that swallow exercise, which I was initially I was not able to do that exercise only, like that swallow and taking out the tongue and doing the swallow. But slowly, I started doing everything on my own. And I could relate to it. The great part of that exercise was I could relate.
Okay. So LSVD is also helping with swallowing and improving swallowing, but it's not replacing swallowing therapy. So doing the motor exercises alone will not result in changes that walk out of the treatment room or last over time. We must address this sensory mismatch match in therapy to have successful long-lasting treatment. LSVD calibration, it addresses the barriers to generalization. People with Parkinson's disease have soft speech, but they think it is within normal limits, that world needs a hearing aid. Speech that is within normal limits, that is normal loudness, is perceived by the individual as too loud. What is the research on LSVD? So this slide highlights the primary outcome variables of sound pressure level across 3 published randomized controlled trials, and the x-axis in each is always the time and the y-axis is in decibels of sound pressure level, and the task of each of these graphs is reading and the rainbow passage. This is a communicative effective index modified. It is a self-reported measure of communication. The 3 groups of participants, that is LSVD, loud, treated, Arctic treated and untreated people with Parkinson's disease. These studies highlight the research beyond just establishing efficacy to documenting the spread of effects beyond vocal loudness, and these studies also help us understand underlying physiological and neurological mechanisms of treatment-related change. This was a small pilot study conducted with 8 participants with Parkinson's disease, and one measure in the study was approximate oral residue. These are primarily data documenting changes in swallowing following LSVD loud, and this is secondary benefit. This is a secondary benefit of voice treatment. LSVD loud does not replace in any way the need of direct swallow therapy for people with Parkinson's disease. This is a second neural imaging study using positron emission tomography, and the results are in the right upright corner. There's a small graph, right, with the behavioral data, and the data are consistent with the improvements in SLP from the previous studies. And the data is like this. It suggests that LSVD loud is basically optimizing the speech network in the brain. So what does this research matter? Why does this research matter? It helps in bringing a strong research evidence to support its efficacy, gives therapists and patients confidence, and it shows through multiple randomized controlled trials the cause and effect relationship between the treatment delivered and the outcome measured. It helps with external validity of research results, advocacy for research service providers, and protects physical, financial, and emotional resources by participating in treatments with efficacy versus potentially ineffective treatments. So I'm moving on to treatment sessions. Daily exercises involve maximum duration of sustained vowel phonation, that is the long R's, minimum 15 repetitions. Moving on to maximum fundamental ranges, high and lows, again 15 each. Maximum functional speech loudness, functional phrases, 5 reps of 10 phrases. Then moving on, these are the daily exercises that they're supposed to do. The hierarchy exercises involve structured, personalized reading and spontaneous speaking for 25 minutes. They build complexity across 4 weeks of treatment. That is, treatment 1 covers words and phrases. Week 2 is sentences, week 3 is reading, and week 4 is conversation. Starting from shorter, simple to more longer, complex. And the homework includes all daily exercises and hierarchy exercises, and they are assigned all 30 days. And carryover to use a voice in real life outside of the treatment room, and it was assigned all 30 days. So, would like to share examples. Calibration, sensory recalibration, retraining the sensory, and learning new internal cue for normal vocal loudness is very essential. These are some of the exercises demonstrated, where the patient is asked to maintain oral loudness. Here is raising functional phrases. and sentences.
He will speak, or I speak. Fuzzy was late. Fuzzy, had no hair. Fuzzy, wasn't very fuzzy, was he? The big flat hair.
One of the videos he's doing the highs, one he's doing the lows, one he's saying the ah, and he's reading phrases. Yeah, so this is a very brief explanation of LSVD BAKE, which offers an interdisciplinary view of treating Parkinson's disease. And another video before and after LSVD BAKE, I'll just be very quick with this. How he was diagnosed with Parkinson's and LSVD BAKE helped him walk. And first day of treatment from the last day of LSVD BAKE. So you can see that he made significant changes on the outcomes. He improved his walking, to go to movies, play with his children, and go for dinner. He was absolutely, he could do his daily activities comfortably and very well. Another technology, LSVD Loud, eLoud for telepractice, and LSVD Companion. These are two types of technologies which are related to LSVD Loud and can also help in bringing in a lot of, it is used to improve the accessibility of the treatment and the research outcomes. This is an example, a video clip of a person with Parkinson's disease using LSVD Companion. This is after treatment, going on over. This patient is with post-DBS. DBS still, another thing what I've noticed is that even with medication or after undergoing DBS surgery, speech doesn't get much affected, as in we have to work on the behavioral therapy aspect of it. DBS post-surgery is definitely helping with the limbs, but speech requires intervention. It's either the same or it has worsened. Thank you. So if our possessions were taken from me, with one exception, I would choose to keep the power of communication, for by it I will soon regain all the rest. Daniel Webster. Thank you. Yeah. We have Tanya now with us. Sorry, Rachel with us. Yeah.
Okay, thank you, Alithya and team. So today we're going to move a little bit into a workshop of this, okay? And also looking beyond idiopathic Parkinson's disease. So as you saw that they've gone through the different stages of Parkinson's research development, LSVD Loud research development, and now when they were at the stage 4, they realized that it doesn't have to be only limited to PD. We're seeing benefits in other people, in cases with dysarthria. We're seeing different effects of this one method. So, to demonstrate, this is what I'll be talking about. We're going to try it ourselves, okay? So do what I do. Everyone's ready? You're going to be doing what I do, okay? Is that your loud voice? Did you hear what I did? Okay. Hear what I do and do it, okay? Very nice. Okay. Do what I do. Sorry. do Okay, so I don't know if you noticed, but did you have any behavioral changes with this? Did you experience something? What? You may have seen your posture change a bit, sit up straighter. You may have taken a bigger breath. You may have opened your mouth a lot more. You may have also thought about your sound. You would be like, oh wait, that wasn't loud, I need to be louder. So that in itself is a neural, at a cognitive level, something is happening, right? You're having a sensory matching. You're matching what your output needs to be. And that is a big part, because when we deal with any of these conditions, it's not just a voice problem, okay? And from research we realize, when we see through a stroboscopy, we're just seeing the vocal fold vibrations, we're seeing the mucosal waves, but to know that voice essentially is also a speech motor function that originates from the brain. And I don't know if you are familiar with the directions into velocities of articulation model by Gunther. You may have studied it in your masters, or we know now that voice from perturbation studies, when people hear pitch changes, frequency changes, whatever, their voice changes as well. So we have a feed forward system, a feedback system, and that results in our voice changing. So there is a cognitive aspect to voice which we cannot ignore, and through LSVT now we're kind of using, we're kind of utilizing. And when I do this, when I showed you what it was, I didn't tell you take a deep breath, I didn't tell you any of these things. I reduced the cognitive load and I just gave you a target, right? I gave you a target and you followed through. Pretty well actually. So when a clinician models and shapes loudness with healthy voice quality, it automatically has this spreading effect over everything else. So when we look at Parkinson's disease, we know that it's a type of, like as speech therapists, we look at it through dysarthria. It has, let's just put this off so there's less feedback. And we're going to use voice as the trigger to impact all of this, to have the spreading effect over all the systems that are affected. No matter whether it's upper motor neuron only, or there's a lower motor neuron aspect, or just flaccid dysarthria, we can use voice to impact everything. As Olivia already pointed out, there's been a wealth of knowledge, wealth of evidence for 30 years. They've been building up. Right now we have these like small single case studies, small study designs, even some random control trials that show that LSVT loud has been used very effectively for all these groups of populations. Even Down syndrome in both pediatric and adult cases, cerebral palsy in pediatric and adult cases, even in dysphagia, although it is not the main method of therapy, as Olivia pointed out, we see this spreading effect automatically into these systems. And why not use it, right? So I want to give you I'm going to focus a little bit on these atypical Parkinson's diseases. Okay? So when do we decide that LSVT loud is a good option? Obviously, with every treatment protocol, with every type of therapy, we follow similarly like some structure, right? We use our clinical judgment, we'll see the medical diagnosis. Importantly, we'll check the stimulability of anything that we do. Is it actually going to work? Should we commit to this type of therapy? So we do this kind of stimulability test. And mostly anyone who has hypophonia, reduced loudness, we can try to use LSVT loud with them. Just to give you an overview of atypical Parkinsonisms, I thought that I'd go into this in a little bit of depth because I have seen a bunch of people with these, and as SLPs, many times people go to the neurologist, they get the PD diagnosis, then they're living their lives with their levodopa, and then they get these speech concerns very quickly, like a very quick onset, swallowing concerns, and they're like, they contract a speech therapist. And then you ask them, when was the last time you went to the neurologist? And they'll be like, oh, recently, or 6 months ago. And you may notice some things which are alarming, which they may think is a part of the normal PD symptomology, but it is not. So I just want to make us also aware, because I have to become aware about these things. When I started seeing like something is wrong here, please go back to your doctor. So, what are the signs of atypical PD? They will start off with PD-like symptoms, right? They'll have the bradykinesia, maybe tremor, maybe instability, but definitely mostly the slowness of movement. They may have some added symptoms. They may not know what's a symptom. Okay? Very commonly, it's like these REM behavioral disorders. While sleeping, they act out things that they otherwise can't do. They'll be dancing in their sleep, they'll be doing things. Now, they're not telling their doctor about this. They're like, she's got some weird dreams, right? They're not thinking that it's a very clear sign that this is something different that's happening. Then the disease course may not be very typical. They do not respond the same way to anti-Parkinson's, whatever, dopaminergic medication, levodopa. And it can be difficult to distinguish from PD initially. But one kind of thing that why we get involved sooner is because speech and swallowing symptoms may present earlier than usual. Typical Parkinson's is very slow progressing. You won't see speech like being horribly affected until later, like 5-6 years, usually after onset. So these are the most common atypical PD Parkinsonisms. There's PSP, progressive supranuclear palsy. The acronym that we can follow, if you see any of these, is FIX. So there'll be frequent sudden falls, ineffective medication. They'll tell you, we don't see anything. You ask them, do you feel better with the levodopa? They'll be like, I don't know anything. The doctor increases, decreases, nothing really happens. They'll have this gaze palsy, speech and swallow changes. Then there's multiple system atrophy, where the autonomic system is also very much affected. That is, the brain is just not sending signals for those respiratory, breathing, like some basic functions. It's not typical signals that are being sent. You have MSA-P and MSA-C. Parkinsonian, which is more the striatal or nigra system is affected, and cerebellar, which is more the pontine cerebellar system is affected. Then we have corticobasal degeneration, where the cognitive changes, the medication issue, asymmetrical presentation, and they'll say there's some odd feelings, movements, clumsiness, Lewy body dementia, progressive cognitive decline. They'll have visual hallucinations, fluctuating cognition, and Parkinsonism. So, yeah. Another thing is the severity of speech. The dysarthria will be much milder for typical PD, and as you can see, it will be either moderate or severe, more likely PSP and MSA. Also, you tend to have more mixed dysarthrias. You'll be like, why is it fluctuating? Why are there these like, sometimes they have some strained voice quality, like where's this coming from? You'll be like, you're supposed to have reduced loudness and everything, and suddenly you'll hear this like strained quality, harsh voice. It's most typically that they have mixed dysarthrias because extrapyramidal system is affected, and so the basal ganglia and the midbrain pons will also have some involvement. So within LSVT loud, what are some adaptations that we can do in complex cases or in these atypical use cases, right? So we can increase repetitions, we can allow for greater rest breaks. Remember that we are always doing this high effort, high intensity. Even when I told you to do it, I didn't say, okay, take a breath or something. I was like, do what I do, and I did it again, right? And if you notice my face, if you notice my body language, is very like, do it. So we may be more gentler for the people who are complex cases. We may persist at shorter phase levels, not forcing them to do conversations, etc., and follow the hierarchy the same way at the same pace. We'll use the family support more, we may accommodate their cognitive issues, and we may add more sessions and follow-ups. However, we cannot reduce, because we're following this treatment protocol, we cannot reduce any of the core factors of this thing, right, of this therapy model, which is 4 times a week, high intensity 1 hour sessions. So now coming to, I'll present 3 cases, and I have a lot of samples from each of them. I just want you to go through, you can tell me if it is too much, and we'll just work through it together. Now you may notice very big differences from what Alifia presented, because those are typical PD cases. When we have someone with more complex needs, when we have someone with so much going on, the difference in results may be less dramatic. And yet, they're pretty cool considering everything, okay? I want to talk about, so I put a picture of my patient and me. It was sent by the family members. She's very close to my heart because she just actually passed away this month, and she was very excited, not really, to be part of this presentation. And so one of the last recordings that I have is actually from this last month of her life. And she was she liked to be very much like the good child, right? Doing everything very well. And so at the end of the recording, she was like, I don't think I did a very good job, to show. Because obviously, at this point, she was already so, much deteriorated. And yet, she was at the end of the video, she was like, but now you'll have to find a new person for your presentation. It's okay, you take me. You add me in your presentations. I said, thank you. And the family really wanted me to talk about this multiple system atrophy and give you some awareness, because they all feel like there's not much out there, and there isn't. Okay, so she's a 64-year-old female with, she had the first signs of Parkinsonism in 2022. Handwriting became smaller, imbalanced, slurred speech, and she did have these RBDs. At the time, the family didn't know that it was important, significant. On the MRI, this hot cross bun sign was formed, which is transverse pontine cerebellum, a line like this and a line like this that comes from the pontine region. It is almost always there in people with MSC cerebellum. Of course, she had poor response to levodopa and a lot of autonomic symptoms, which is rapid breathing, incontinence. Towards the end, I'll tell you what other things she had, but she had this anoxic seizure type thing where her brain would she would get a little stressed, her breathing would change, and then the brain would not send signal to breathe. So she would actually go blue and need to be resuscitated, and it probably happened about 40 times in the last year. So, yeah. I'm going to play a sample from our first, during our LSVT assessment, we do this thing where they are supposed to talk about something where they are happy, so their emotions are high. And already we're kind of stimulating a loud voice speech.
Any time in the past where you were very happy?
Please ignore all my Can you, what would your... Okay. Right, so would you say that, I don't know, maybe I feel like my intelligibility is a little biased because I'm used to her. But did you all appreciate, like you can hear there is like less mouth opening, there's articulately like the vowel spaces are not adequate, right? All of these things you can hear it. There's also these kind of spurts, something more clear than something rushed. Okay. Alright, so this is the stimulability test. I don't know.
Say hello and loud as possible. Hello.
The same day, okay? This is the assessment day.
Okay. Good morning. Good morning.
So from this we can tell that she's able to do it. The capability is not less. It's just because of that extrapyramidal involvement that her perception of her speech is so reduced. She thinks she's shouting, but she's not. When I cue her appropriately, she's able to perform this speech. This is after the 1 month of therapy. Can you hear the difference? She's still talking about the happiest day. So she's saying, I see if the dopamine can be rejuvenated again. So this is union. So I cue So within the, I'm cueing her, I said, is that a loud voice? And she did Jack and she was better. Okay. This one. So you can see she's really able to drive the motor system. She's getting all the strength and, like, you know, essentially why we do LSVT loud, we're giving that, because we're giving that proper amount of stimulus to the vocal cords. The natural wasting that happens from not being used doesn't happen, and we maintain the integrity, the quality of the muscular system. This is the video she made for me at the end. This is still 1.5 years after we started, okay? We started November 24. So even though her disease had progressed so much, her voice, and she still didn't have that many swallowing issues. She was still eating everything on her own. You can tell, like, you can see her mouth has, there's some wasting with her lips. It's become thinner. She's gently been going down only, but still we've been able to maintain communication.
You can tell me
Okay. And now, if we have a little bit more time, I'll just talk about a case of progressive supranuclear palsy that I have. He's a 73-year-old male. So when we saw in the MSA case, the pons was more affected. We see more atrophy in the midbrain for people with PSP. He's had changes in walking, imbalance, and speech since the beginning. So again, how we know it's atypical PD, and his doctors knew from there only something was different. He's also had on his PET scan hypometabolism of the bilateral frontal, temporal, and cerebellum. which is why he's also had a lot of cognitive issues. So I just want to give this case to illustrate about how it's not the best use case, okay? It's not like you'll see because of his cognitive issues, because of the other aspects. He's not like a great candidate for LSVT, but yet, okay, yet it's working out very well. So I'll just, interestingly, see what I'm giving him, and notice his vowel distortions. It's more like apraxic, like kind of progressive apraxia that's happening. Unfortunately, there's not much data. I tried to look up whether PSP has progressive apraxia involvement, but there's not much data in it, but I think that's what he has. Because it's become a little worse over time. But okay, I'll just play this for you. This was again last year. You can hear this is him not being very loud. He's repeating out. Like functional exercise, functional phrases. This is him reading. So it's harder and harder for me to get him to write that much. And because of the cognitive issues, he's just generally not that interested in communicating with his family, even though that was his big joy in the beginning. I'm just going to go quickly through this. Let's look here. You may have noticed the differences between the two groups, the two cases. The MSA, it was not as disfluent. You could still understand, but she had these like kind of like maybe some intensity variations, bursts of speech. But you can see with PSP, there's more like everything sounds very labored, all his words, everything comes out with a lot of effort, that harsh voice. And now I want to show you, because I think everyone doesn't see PD cases, okay, right? But we see a lot of stroke patients. And this was a kind of interesting discovery that I made on one of the people who had like severe dysarthria. And I was like, what are we going to do? He already had gone for therapy for 2 years or something at this point. He was kind of like had locked-in syndrome adjacent. When I met him, it's okay. Yeah, I'll play. You don't know the context, you don't know. He's making fun of Trump. He's like, he studied here only. He failed in English. He was in Nanapet. He's a big joker. And he said, please use my face, and I want people to know who I am. So, if anyone wants. So this is him. I've not done proper LSVT with him. This was just stimulation over time, because the time constraints, he's not available more than once a week, once or twice a week. I'm not available more than twice a week to see him. So we've not done proper LSVT, but just to show how he's a good candidate. Before, he used to actually just talk like this. Like it was kind of paradoxical breathing, and he used to just be like, so for half the year, I don't have speech samples only because I should have taken, but I didn't.
Okay, say one thing versus
The fact that he's getting any pressure consonants is amazing, right? He had a lot of drooping on this side.
press here.
He's approximating, his lips are approximating well. coordinate the air coming out and everything. Even blend. Okay? Alright. So thank you very much. I just want to say, like, I'm not like, I don't love neurodegenerative disorders, but they started coming to me and I felt like it was my responsibility to equip myself, and I had this, like, obviously, like, why do anything if they're anyway going to dying, and I don't really want to be part of this whole process. But we have stepped into this profession and we do owe it to our patients to be the best versions of ourselves, to manage our emotions, to show up for them, to equip ourselves well. And I want to encourage you, it may not be the best, like, funnest experience, but it is kind of like a thing that we get to do, good or bad, and I just encourage you to step into it, learn, equip yourself. And I just want to thank all my patients for agreeing to be part of this, and they were really, like, enthusiastic, like, please share, please let other people know how to help us. So this is me sharing the knowledge. Please keep continue learning and keep that on.
Thank you so much for a wonderful session. Does anyone have questions? Okay, so we want to felicitation. I would like to request you, sir, to felicitate our guest. Govind, sir. Rachel, ma'am. Congratulations to all the panelists. Now I would like to request, please gather for the photograph at the same spot like we have yesterday met, just in front of the engineering college. It's mandatory for RCS, so